Hello, and welcome to Avenger's virtual series of webinars. Thank you for joining us today. Today, we will be discussing new approaches to treating peripheral artery disease below the knee and promising new BTK data. A panel of leading interventionalists with extensive experience treating PAD will be presenting today. Please note that these presentations have been pre-recorded specifically for this webinar, but we are also joined live by all of our presenters for a question and answer session at the end of the pre-recorded agenda. Participants will not be able to unmute during the session. However, you may pose questions to our panelists at the end of the prepared remarks during the Q&A portion of the webinar by clicking on the Q&A button and typing in your question. This webinar will be recorded. We will now introduce our presenters. Dr. Thomas Davis, with over 3 decades of clinical practice and leadership in cardiovascular medicine, Dr. Tom Davis has pioneered the use of cutting-edge interventional technologies to treat lower extremity arterial disease. Dr. Davis is the Chief Medical Officer at Avenger and a practicing interventional cardiologist focused on peripheral artery disease and non-surgical limb salvage. He also serves as Director of Cardiovascular Research at St. John Hospital and Medical Center in Detroit, Michigan, and previously had the leadership role of Director of the Cardiac Catheterization Lab and Director of Peripheral Interventions at the same institute. Dr. Davis works on several scientific advisory boards for interventional device development and has participated as an investigator in multiple clinical trials for new endovascular technologies. Dr. Mikhail Lichtenberg is an angiologist and the Chief Medical Officer and Director of the Angiology Department and Vascular Center at the Arnsberg Clinic in Arnsberg, Germany, one of the largest interventional angiology clinics in Germany. Dr. Lichtenberg has over 20 years of experience in endovascular interventions and has served as the Managing Director and President of the German Society for Angiology. He has been a pioneer in the evaluation of new medical devices, techniques, and procedures for peripheral artery disease and served as an investigator in many clinical trials within the vascular space. He has received board certification in angiology and cardiology and has been extensively published in peer-reviewed journals. Dr. Philip Young is a board-certified vascular surgeon specializing in both vascular and endovascular surgery within the Houston Methodist system. He treats all forms of arterial and venous disorders and has authored several publications on the treatment of vascular disease in the Journal of Vascular Surgery and Annals of Vascular Surgery. His research interests include vascular imaging and its applications to peripheral arterial disease, transcranial Doppler and real-time cerebral monitoring during carotid interventions, chronic central venous occlusive disorders and management, as well as indwelling inferior vena cava filters, evaluation and surgical endovascular retrieval. Our agenda today is as follows. Dr. Lichtenberg will present the challenges of treating below-the-knee arterial disease and provide future perspectives on treating BTK and critical limb ischemia. Dr. Davis will present an overview of an image-guided treatment device designed to address some of these challenges of treating BTK and also review the interim results of the IMAGE BTK study, a prospective global multi-center trial studying the treatment of below-the-knee lesions with this technology. Dr. Young will follow with the presentation of a case study showing the use of image-guided treatment to target multi-level PAD. We will conclude with a question and answer session with our panelists and moderated by Dr. Davis. Now, please welcome Dr. Mikhail Lichtenberg.
Hello, my name is Michael Lichtenberg from Arnsberg Vascular Center. Pleasure to be here today and to present on the future perspective in BTK and critical limb ischemia treatment. Here my conflict of interest, my disclosure slide. So we are all aware that critical limb ischemia patients have an extremely poor prognosis. We know this for many, many years. You can see this here again, this summary slide. 25% of critical limb ischemia patients die within 1 year 50% will have amputation with continued critical limb ischemia, and only 25% of the patient will have critical limb ischemia resolved in 1 year. So there's a clear need for us to take care about this patient. And I would like to discuss a little about the best ways how to recanalize and to definitely improve clinical outcome for these patients with critical limb ischemia. Despite clear guidelines, we know that the majority of CLTI patients undergo leg amputation without angiography or revascularization. This is, I think, still a very bad situation, unfortunately, a reality. 150,000 amputations per year are still fact for patients with critical limb ischemia. So that means we have to improve the outcome of these patients. We have to raise the awareness for critical limb ischemia patients. So with that support, I think we can much better do for these patients in terms of their clinical outcome and prevent amputation in these patients. When we look at the major economic burden in Europe, for example, England and Germany, you can clearly see that patients with critical limb ischemia cause a high economic issue for all the healthcare systems. When you look at Germany, for example, you see the total hospital reimbursement for critical limb ischemia patient exceeded 1.1 billion in 2007, and it rose to 1.3 billion in 2029. So there's an increase of 21% within 2 years, which I think is due to the fact that more and more patients with risk factors show up very late with critical limb ischemia stage. We know that BTK disease is characterized by a very challenging morphology. This is typically characterized by complex morphology with long diffuse vessels, heavy calcified vessels, and total occlusions are very common, as you can see here on this slide example on the right side. But we also know that BTK lesions especially are unique from other vascular beds. When we look here at the morphology analysis, you can see that BTK occlusions are chronic in nature and at least one half of the lesions were embolic in origin. And if you compare this distal morphology to more proximal morphology, you can clearly see this, especially lipid core and fibrosis or lipid core alone is much more predominant in more proximal disease than in distal disease, whereas in distal disease, we have chronic occlusions, intimar calcification, medial calcification. And this is a quite challenging morphology, especially for revascularization. We know that calcification in particular promotes recon and dissection, a natural reaction we unfortunately face after standard balloon angioplasty. We know that intimar calcification is disorganized and not structured. And on the other hand, medial calcification, the vessel wall, is organized and structured in recent shapes. And this means we have areas with more disease, less disease. And this, of course, then leads to very impressive recoil, which is frequently observed in critical limb patients undergoing tubular angioplasty. We unfortunately have to admit that we have this seen already for 10 years, but unfortunately did not take it in our daily routine practice. Frederick Baumann from Switzerland 10 years ago already described that in his publication in the Journal of Endovascular Therapy that 97% of the vessels had evidence of recall 15 minutes after PTA. And there's a nice example on the right side here of the slide. You see after PTA, the immediately post-PTA outcome looked fantastic. But after 50 minutes, he performed in re-angio and you see the significant recoil. So we are heroes for 50 minutes, and then after 50 minutes, we become losers. Again, this has something to do with the recall answer, and this is due to the wall compliance mismatch, which can contribute to recall and dissection. And the explanation for this is quite simple. And we see this on the left side, where we have, as already mentioned, stiff calcified segments, and on the other side, more soft plug segments. And if you just inflate a balloon in this area of soft and calcified segments, there's a dissection site in between because of a high tension force on this part, which then causes dissection. But on the other hand, the soft plug segment bails out and comes back as a recall answer, whereas the stiff calcified segment is not bailing out, typically has more dissections. As we know that not all dissections need to be treated, we know that even non-low flow limiting dissections are not benign. That means we have to observe if there are dissections occurring after standard balloon angioplasty. Dissection is an important mechanism to gain lumen area after PTA. So we have to analyze if the dissection which we caused is something we need to treat or we can leave behind. And this is sometimes very difficult, especially in BTK lesions, because they are not very easy to see, especially if there's a lot of calcification. We definitely know that high-grade dissection predict a higher target lesion revascularization and a reduced patency. So we should definitely treat high-grade dissection to prevent restenosis and to improve patency outcome. You see the restenosis or reocclusion can occur in nearly 70% of patients within 3 months of intrapopliteal PTA and long lesions, based on historic data by Andrew Schmidt and Professor Scheinert from Leipzig in 2010. After angioplasty on the right side, the tibial and the posterior artery showed very nice, but 3 months later, reocclusion of the anterior tibial artery was seen. And this was probably due to because of dissection and the recall answer. So the question is, what can we do to improve this? Because if we do not improve the restenosis process caused by recall, by dissection, then we definitely increase the frequency of amputation during time. And this means we have to do a better job in terms of lumen gain, stable lumen gain, prevent restenosis from a technical point of view to prevent major amputation or minor amputation during the follow-up. We learned also from Professor Jihad Mustafa that especially recall has a significant impact on the clinical outcome and patency rate in these patients after standard balloon angioplasty in BTK vessels. Some modern technology now address this issue of recall, and we could show in a recent publication that especially with dedicated devices like scoring devices or atherectomy, the recall answer diminishes in comparison to a standard balloon angioplasty. Just to have a look here at a publication we recently performed with a scoring device, you can see here in the comparison group with a POBA angioplasty that after insufflation, we had a very good outcome, immediate outcome after angioplasty, but after 50 minutes, you could see an elastic recall of 100% and a residual stenosis of 77%. And of course, it's easy definitely to interpret that these patients definitely do not have a very good outcome in terms of their freedom from restenosis and freedom from reintervention. So we have to break this vicious circle caused by standard balloon angioplasty. So how can we improve lumen gain and prevent recall, and on the other hand, prevent from barotrauma, so that we are not forced because of dissections, because of recall, to implant long stents, when we of course now then are also on a high risk for restenosis, and then we are back in this vicious circle. So what can we do to improve long-term patency rate? So could we achieve better long-term patency rate with better understanding of the lesion morphology using IVUS or especially OCT, and identify the areas where recall occurs or the dissection answers occurs after standard balloon angioplasty? Should we switch from a standard balloon angioplasty to a dedicated lesion preparation using scoring devices atherectomy? Question mark. Is drug-eluting balloon angioplasty really the answer to all these problems? Probably not. Is a different drug-coated balloon technology maybe an answer? I'm not sure, definitely. But what we definitely know is that if we identify the dissection on IVUS or on OCT, we can definitely treat these remaining dissections and prevent the restenosis reaction of the treated vessels. So what are the advantages of an intravascular imaging in BTK procedures? May this improve the technical, procedural, and clinical outcome of our patients, which we treated with angioplasty below the knees? First of all, I think it's important that accurate sizing by angiography is challenging, but definitely very important in small arteries. If we perform a very good sizing of these devices, we can create stable lumen and enough lumen to improve the blood vessel, the blood flow to the foot and forefoot. But it's not very easy based on angio to really determine the diameter, the reference diameter. So adequate measurement is important, and I think IVUS and OCT management is something we should implement to definitely size reference vessel diameter correctly. To prove this a little bit, we performed a hypothesis-generating study, the Prestige trial, where we included 50 patients within a prospective single-arm multi-center trial, patients with Rutherford 4 and 5 scale. We used IVUS-driven atherectomy in this trial to learn if this approach with an IVUS-guided intervention could improve clinical outcome with patients with critical limb ischemia. So we included patients with diffuse disease of BTK lesions, as you can see here, the location on the left side. We also include patients with severe calcification and also lesions which were longer than 20 centimeters in many of the cases. What we found, and this was a collab adjudicated study on the analysis, that baseline reference vessel diameter was totally different in the angio assessment versus the IVUS assessment. The difference was 1.24 millimeter. So we typically undersize the reference vessel diameter based on angio measurement, whereas IVUS could give us a much better information about the correct reference vessel diameter. So therefore, I think IVUS OCT have clear advantages in analyzing many factors which are important for the technical and procedural outcome for BTK lesions. Where's the calcification? The distribution of calcification is especially, as mentioned, the correct vessel diameter assessment and the assessment of dissection complexity post PTA. Angio, we know, has limitation in regards to the severity of calcification, thrombus assessment, correct vessel diameter, and the number and severity of dissections. So I definitely would like to advocate that modern modalities, diagnostic modalities, including OCT and or IVUS, have advantages over angio analysis. So therefore, in conclusion, my personal point of view is that vessel preparation can be considered as a must in many BTK lesions to improve the compliance of the vessel, to reduce recall, answer, and dissections. But we, I think, should include and implement different diagnostic modalities, including OCT and or IVUS, which are helpful to guide revascularization, to prevent dissection, and especially improve lumen gain. Lesion preparation may further improve technical success and clinical outcomes. First data have proven this, but the long-term clinical data for this approach are still missing, especially for lesion preparation strategy. Further prospective, very well controlled studies are needed here. If we need to combine this with DCB, this is definitely something we can't answer yet. So far, we do not have good data for drug-eluting balloons below the knee. So we should also include DCB, including also sirolimus DCB, angioplasty in these trials to assess if a combination of a lesion preparation strategy plus a modern DCB angioplasty could improve the clinical outcome of our patients. Thank you very much.
Thank you so much, Dr. Lichtenberg, for such a thorough and research-driven presentation. Your detailed insights and data have given us a lot to consider and provided valuable takeaways. Now, Dr. Davis will present an overview of an image-guided treatment device designed to address some of the challenges in treating BTK. He will also review the interim results of the IMAGE BTK study, a prospective global multi-center trial focused on treating below-the-knee lesions with this innovative technology.
I'm Dr. Tom Davis. This talk is going to go over the Pantheris SV device overview to give you a better idea of the device itself and its working components. So this is the Pantheris SV system. You can see the light box in the center with the dimensions, and it can sit on a rolling sort of table, an aspect that it connects to. And then the actual device itself that will connect into the sled, which then connects the device to the light box to the fiber optics can be seen on the box itself. So we're talking about real-time imaging, and I think this is the real big point of the device, because it's the only device out there that does have imaging capability to it. So it takes imaging to another level from just a diagnostic tool to really a therapeutic interventional tool. So you can see on the left the clear visualization of the plaque, the cutter with the cutter open, sort of pointing at 7 o'clock. You can see the dark line there that is the media coming in, and the plaque that's there as well. Under fluoro guidance, and for those of you who have used directional atherectomy on fluoro guidance, really you can see that as you're advancing that cutter, you really don't know where the plaque is, which direction you have to cut, and you can't really tell what's healthy tissue and non-healthy tissue. So imaging does give you that benefit of being able to see just the plaque distribution, as well as not to cut into healthy tissue. So this is the device itself in a schematic diagram, where you can see with the cutter is open in this scheme, pointing toward, you can see the plaque at the top. You can see the middle marker is behind the cutting device. So if you look at the right screen, those three sort of like tails, you can see the back tail is the middle marker, and that is the opposite direction of the cutter activation. So again, here's more of a live schematic presentation of it. You can see the device, which is for relatively 2 to 4 millimeter vessels. You can see the nose cone, which captures the debris, is 3.5 centimeters. In this blade, you can see, picture the blade is open and the imaging fiber on the cutter edge. And so it looks right directly where the cutter is cutting into. You can see the middle marker on the back, and where it looks into on the real image on the right. And you can see the apposition jog. So the old devices had balloons on them. This jog allows the, when the cutter is open, to push it into the plaque, effectively being able to shave when you advance the cutter. So this is an example of an excision loop. And as you can see, this is when the cutter's open. You can see actually the media as you're advancing. And so your hand advancing slowly. You can see the cutter being at about 6 o'clock right now. And you can see all the imaging fibers. You can see all the plaque. You can see some of these lucent areas being calcium. And you can also see the media quite well. You can see these lines associated on there. When the cutter closes, you can actually, you lose the image, and that's when you're advancing the knob to close the cutter itself. But you can see that by this image that you can rotate the catheter as well too, to point towards the debris as you can see it. And you can actually see When you see that you get closer to the media, you can close the cutter and actually rotate the cutter back into debris areas and trying to avoid the media itself. Sort of the advantages of OCT guidance for below the knee treatment. I think we've already shown that these vessels are unique. The below the knee vessels are unique in terms of that peripheral vascular disease being smaller and being more medial calcification. So it really, when you can see what you're cutting, you avoid the adventitia and vascular injury to more healthy tissue or healthy media. You have much more precision as this disease tends to be asymmetrical. And as you can see, that the nice thing about this is you can rotate the device towards the plaque, avoiding more healthy tissue and certainly avoiding causing perforations into the adventitia. It gives you a better assessment of the disease. As you can see on that video loop, you can see little calcified areas or lipid pools in that degree. You can see the media very well. And in some cases in the peripheral vasculature, the media is actually destroyed. So you can see plaque, and then as you're cutting along, you almost come right up to adventitia immediately because that media just thins out and gets destroyed. The other thing is for accurate adjunctive balloon or stenting sizing in the below the knee vessels. Reducing patient contrast exposure. I know my fellows who should be listening today can attest that they're actually shocked is when we've done the whole vessel below the knee as we've traversed down. When they actually turn on the fluoro, there's sometimes surprised how far down the vessel path we have gone. But many of these patients have impaired kidney function, being diabetic, elderly, and therefore it does limit contrast exposure. And the other thing that's very important with OCT guidance is reduction of radiation exposure. You'll see various studies out there using these devices that cuts down radiation, can cut it down actually 80–90% while doing these procedures. You don't have to have fluoro on. You're imaging through that OCT, and that's what you're watching and not the fluoroscopy anymore. You can be much more accurate and much better at imaging or seeing what you're cutting in that degree. This is an example case study of one that was used below the knee. You can see prior to the treatment on the left, where the anterior tibial and the tibial perineal posterior tibial aspect is subtotally and even totally occluded in some degrees. You can see during treatment on the middle one, you can see the actual image, OCT image, where actually the media actually looks pretty healthy here, and markedly that you can see that this is more fibrous tissue in that degree. And then the anterior tibia was treated as well with this device, and you can see the post-treatment picture on the far right side of the screen, looking very excellent without really any dissections. You can see the actual size of the vessel. There's very little residual stenosis compared proximal and distal areas of that vessel. So I hope this overview was informative and helpful, and hopefully that you'll be successful in treating the below the knee cases, very similar to this case that you have just seen here. Thank you. I'm here today to go over our IMAGE BTK trial interim outcomes, which I think are very exciting data that I think everyone's going to want to see, and hopefully will be as impressed as I am. So the overview of BTK image, it's assessment of the utility of the Pantheris SV system. So the trial design, prospective, global, single arm, and multi-center. We had 4 centers, 2 USA sites and 2 Eastern European sites or European. We had images go to core lab, were adjudicated, and AEs assessed by a CEC committee. We had safety endpoints primary were freedom from MAE through 30-day follow-up. And we had effective endpoints for secondary endpoints, in addition to the primary of less than 50% post-atherectomy. Then secondary was residual stenosis less than 30% post-atherectomy. Residual stenosis less than 30% adjunctive therapy, freedom from TVR at 6 and 12 months. Primary patency with Doppler ultrasound at 6 and 12 post months, improvement in ABI, and a decrease in Rutherford class. So on the exclusion criteria, any subject that was over 18 years of old, who had target lesions in the popliteal or below, patient had at least one pedal vessel noted in the foot, and the Rutherford class was categorized as 3 to 6. Exclusion criteria were surgical or endovascular procedure within 10 days prior to the index procedure in the same limb, had planned surgical procedure in the same limb within 10 days after the index procedure, had a major bleeding event within 30 days prior to the index procedure, has anticipated life expectancy of less than 1.5 years, and is unwilling to present to investigator for 30-day, 6-month, and 12-month follow-up assessment. So on the data collected to date, this is a summary of the results. We have 51 patients enrolled, 58 lesions treated, 45 patients were at 6 months, and 33 patients were at 12 months. And some of the amazing data that I find on this that really was eye-popping, even though this is a small volume of patients, we had 96% freedom from target lesion revascularization at 6 months, 97% freedom TLR at 12 months, 96% primary patency rate, and this is by duplex, at 6 months, and 94% patency rate by duplex at 12 months. Really unheard of in the infrapopliteal segment for treatment, especially when you compare it to balloon angioplasty. The safety was equally impressive. 100% freedom from major adverse events at 30 days. All-cause mortality rate at 30 days was 0%. And again, major unplanned amputation was 0%. So incredible safety data as well as efficacy data out to 6 and 12 months. Patient demographics, risk factors, a third of them were male, a third were female, 2/3 were male. Ages were on the average of 73. Weight on the average was 87 kilograms. Height was 172. You can see 80% were Caucasian and 20% African American, and the average ABI was 0.68. You can see the Rutherford classes that were 3, 4, and 5. Most of these patients were Rutherford class 5, so a significant risk patient burden. Risk factors, you can see history of smoking, hypertension, CAD, and diabetes. The lesion characteristics, as you can see, the mean vessel diameter was 3.2 centimeters. Lesion length was a very robust 11.5 centimeters. Mean percent diameter stenosis was 94%, and 87% of these were de novo lesions. As you can see the location, the majority of these patients were either in the AT or the PT. There was a few in the TP trunk, dorsalis pedis is far down there, and 5% in the perineum. You can see the degree of calcification. None was only 15%, so 85% of these patients had a smattering of mild, moderate, or severe calcium as assessed by radiographic. Effectiveness endpoints for luminal gain, which was one of the secondary endpoints. You can see 94% pre-procedure down to post-Pantheris, only 21%, which is 73% luminal gain. And again, somewhat better post-adjunctive, but the biggest bang for the buck was really in the post-atherectomy luminal gain. And again, you can see primary 98% residual stenosis had after less than 50% after Pantheris, 100% met in the secondary endpoints less than 30%, 96% freedom from TLR at 6 months, 97% freedom from TLR at 12, 96% patency at 6 months and 94% again patency at 12 months. Again, I think are really almost eye-popping results. Again, tempered a little bit by the low percentage of patients. However, even in this small group of patients, these type of outcomes are really unheard of in any type of publications. Other important outcomes, procedure time, improvement in Rutherford class. So you can see on the left at the baseline, the majority of these patients were 46% Rutherford 5. You can see at 30 days, 6 months, and 12 months, 78% were either a Rutherford class 0 or 1. So again, for infrapopliteal vessels that we're talking about, durability, which I think is important to limb salvage, at least in the first year, is as astounding, as I said, 78%, which is, again, I have not seen that published anywhere. Elapsed procedural times, mean total time was, mean total procedure time was 1 hour and 11 minutes. You can see the mean atherectomy time, 8 minutes. And again, finished discharge was as low, 1 hour and 35 minutes, and 3 hours again from mean start to discharge. So again, these patients many of them were done in an outpatient center, and patients can be safely discharged very quickly. Looking at the analysis of the excised tissue, the constituents, you can see mean tissue weight was 21 milligrams. Most of this, there was a lot of smooth muscle cell rich plaque that was in these, and you can see areas of lipids and inflammation, thrombus, 22% area of media, and a very minute amount of adventitia. What was surprising here is really we don't see a lot of calcium, where even though you see radiographic calcification, the amount of calcium is actually in the media itself. And you can see this on the OCT images as you're doing this. Most of the actual luminal tissue is more fibrous and smooth muscle cells, which I think, again, looking radiographically, it gives us a false sense that this is all calcified when it's really all medial calcification. So in conclusions, Pantheris SV provides effective and safe luminal gain, 73% reduction in stenosis with just a Pantheris, and a 90% with properly sized adjunctive therapy. Less than 1% adventitia, which I think makes this a very safe device because you're not having small perforations in the tibial vessels. So this was in the excised tissue, and 100% freedom from device-related adverse events at 30 days. One of the fears I hear from people is saying the risk of perforation down in the tibial vessels with the possibility of compartment syndrome. Again, we did not see this, and we, as you're imaging as you're going along, it's just you don't really see adventitia in the tissue that you're bringing. Patient symptoms dramatically improved post-Pantheris. There was a marked reduction in Rutherford class, and which stayed through 1 year, so very durability of the procedure. There was an increase in the ABI through 1 year post-procedure. And again, Pantheris SP produces sustained outcomes over 12 months. Freedom from target lesion revascularization through 12 months of 97%. Superior vessel patency 1 year by duplex ultrasound of 94%. Again, numbers that I think are just amazing, and numbers I have never seen treating infrapopliteal disease, and for that matter. So again, I want to thank you for allowing me to present this data, this really exciting data to you. And I hope you can apply this to your practice moving forward.
Thank you, Dr. Davis, for the detailed overview of the image-guided treatment device and the encouraging interim results from the IMAGE BTK study. Up next, Dr. Oyoung will present a case study highlighting how image-guided treatment is being applied to address multi-level PAD, providing practical insights into its impact on patient outcomes.
Hello, my name is Philip Oyoung. I'm a vascular surgeon at Houston Methodist Hospital. I practice at Houston Methodist Katy. This is a case of a superficial artery and posterior tibial artery lesion that I treated. So in this certain case of a 95-year-old male who had a remote stent placement in the superficial femoral artery. The patient was referred to me for lifestyle limiting claudication. In this case, we had an extensive stent occlusion, and when I brought the patient for an angiogram, it's identified a complete occlusion with reconstitution of the popliteal artery above the knee with 2 vessel runoff, but also pretty severe stenosis of the distal posterior tibial artery. For this procedure, I gained up and over access, and I was able to recanalize the stent by using a crossing catheter and a stiff glide wire. It's very important to stay within the lumen of the stent and not extraluminal in order to have a successful treatment. The first image demonstrates the angiographic results and the occlusion of the stent. The second image here is demonstrating the crossing of the lesion, and also after the atherectomy of the CTO with luminal gain. Once I was able to successfully atherectomize and gain luminal or have luminal gain, I restented the entire stent with Viabonds and bookended the 2 with drug-eluting stents with excellent results. The image on the right demonstrates OCT image guidance and being able to see the sides of the struts of the stent very easily. In this image here, we have the arterial layers, which are visible under OCT image guidance. We can very clearly see the plaque, as well as the media and the external elastic lamina. On this video, we demonstrate the real-time OCT image guidance, which assists with excision of plaque and avoiding the healthy media, which is very important to avoid injury to the media, potential perforation, and extravasation. This is a still image of the excision of the media for maximum, up to the media for maximum luminal gain. You can clearly see where the plaque ends and the media begins, and the external elastic lamina. This is another video with OCT guidance. We can ensure that we are maintaining the media without perforation. This allows for more complete and effective atherectomy with maximal luminal gain. Again, this is a still image, and this allows us to precisely avoid healthy layers for best-in-class safety. This is very important. We have a compressed media here, which is very close to the adventitia. We can use this to help us stop the atherectomy before we excise the media. And we only want to focus on the plaque. This is another video of us treating the below knee lesion with OCT guidance. And this is the pre and post images with our final results. This demonstrates excellent improvement in patency of the posterior tibial artery after Panther's atherectomy and angioplasty. This is very important for maintaining the patency of the stent, as it's very important to have excellent outflow to maintain the patency of the stent. So the key takeaways for the Panthers, the key highlights is the criticality of safety and precision in below knee interventions due to increased risk of perforations and flow limiting dissections. OCT guidance, directional excision mechanism, and torque control provides Panthers with the precision required to avoid perforations and dissections, treating only the disease and keeping healthy tissue intact. The Panthers OCT guidance and directional atherectomy results in excellent resolution of stenosis by enabling substantial and non-disruptive luminal gain. In this case, 80% stenosis to 10%. Panthers provides flexibility in treatment for above and below the knee and in semi-stenosis and complete total occlusion. Thank you.
Dr. Oyoung, for your illuminating case study presentation. And now we open the floor to the Q&A session hosted by Dr. Davis.
Thanks.
Hello. Welcome to Avengers of Virtual.
Just getting over speaking there. Well, again, I want to thank you two for for the case presentation, and again the thoughtful, thought-provoking talk that you had, Michael. We do have a couple questions. I think first, throw it out to both of you. Any suggestions for embolic protection in BTK revascularization when using this device? Do you see much distal embolization when using the below the knee device as compared to above? And do you do some form of distal protection?
I
Yep.
can start here. So in my limited experience, I actually haven't needed to use distal embolic protection. I generally try to select patients that have more chronic disease, and I haven't had any issues of that yet. I am very careful to continuously close the cutter. I feel that if you do too long of a segment without closing the cutter, you are at risk of losing some plaque and distal embolization. But I think most importantly is patient selection, understanding that if it's more chronic disease. And I haven't had to use distal embolic protection in my cases.
Michael, how about you?
Yeah, I fully agree. I think these are very important points. Patient selection is key. Whenever I see on OCT, by the way, thrombotic material, I would not recommend to use the system. The 6-French device, based on my experience, does not need any embolic protection. For the 7-French device treating SFA, popliteal artery, yes, this is recommended. But for the 6-French device below the knee, I do not use any embolic protection.
I think I don't either myself. I think the device, as you said, 6 French, it really fills the vessel up fairly well. And there's not as much room, I think, for embolic debris to go downstream. And I think the other thing too is we're usually treating total occlusions. And so therefore you're not going to get debris going downstream, and you're not usually doing more than 1 or 2 passes, I think. So I think it's not as important. I'm sure there's other people out there that would disagree with that, but anyways, another question that came up, and I have an additional one for that. How do the image BTK data compare to other technologies for treating BTK that you have used? And one further aspect to that, what 1 or 2 things that the image BTK or imaging atherectomy device gives you a better outcome and result in below the knee disease? What would be 1 or 2 specific things that you think it's better with? Mike, I'll let you go first this time.
So I think these very impressive BTK outcome data clearly show it is so important to see what you are treating. I think based on these OCT images, you can much better create a stable lumen without any issues, which we would see on standard technology using POBR or even scoring technology. So we can much more focus on the eccentric plaque. With that, create a much better lumen. Actually, and Tom, you're so right. We were also surprised about the very good outcome data. And I think these outcome data, the clinical outcome data for our patients, prove that it is important to see what you are debulking. And I think this is key factor because we know that especially BTK, we are seeing a lot of eccentric, not only concentric lesions. And if we don't see adequately the eccentric lesion, we do not even know what to treat. And then we have overextension, we have a standard balloon technology creating dissections and recall. And with the treatment of these eccentric lesions, so improving vessel wall compliance, we are getting much better compliance of the vessel, avoiding dissection, avoiding recoil. And with that, and this is my personal hypothesis proven by the BTK data, are creating much better stable lumen and better clinical outcome. And then this is what I think the BTK data just showed us.
Philip, how about yourself?
Yeah, I totally agree with Dr. Lichtenberg and his slides that, the eccentric type of plaque and, the type of recoil. And the vessels are elastic in some form or way, at least normal vessel is. And as they age and their disease, maybe parts are not as elastic, but still, you can balloon one side or balloon the vessel and it just recoil or expands on one side. So I think it's extremely important for the image guidance, and that's what drew me to the device to begin with, was that the image guidance and the ability to focus your treatment on those. And I think as we've seen in the development of treatment of the vascular space, imaging technology completely changes everything, from ultrasound guidance, percutaneous access to real-time imaging of, cerebral brain flow that we mentioned earlier that I've investigated. As we get better and better technology, it continues to improve what we can do in the space. And so I only see imaging as an adjunct to improve our outcomes. And I feel that, I've seen that so far in my experience with this device.
How important, for both of you, uh, when I do these things, and again, the more you learn, the more you're able to not use fluoro, obviously, while you're doing your atherectomy and imaging. How often do you see that the disease that you see on angiography is very limited compared to the disease that you're actually treating? I find myself, cutting at the beginning of the lesion, then going, and all of a sudden I look on fluoro and I'm like, I'm way beyond, and I've just found all this disease distally. How often do you see that, and how important it is that we have to treat all this disease rather than just focal areas that are more severe?
Yeah, absolutely. Angiography is a 2-day image. So if you're not catching any anterior posterior stenosis in those cases, unless you're doing, rotational angiography or multiple views. So you're only getting one picture, and it's a 2-dimensional picture when disease is 3-dimensional. So you're absolutely missing a lot if you're not including imaging of the entire system. And therefore, that's why IVUS is such a good adjunct as well. You're seeing a lot more than what you would on angiography. Absolutely.
Mike, how about you?
Yeah, I fully agree with what Dr. Hoyong said. BTK disease means we have a lot of distribution of calcification, small, tiny vessels. We have a lot of bone overlap. And we have CLI patients, dementia patients, which are moving a lot. So it means we have to do a lot of images, different angulations, so a lot of X-ray exposure, a lot of contrast to get informations. And with this all challenging situations, we are missing these informations, and with just one OCT or IVUS analysis, we get all these information. So less radiation, less contrast, not influenced by shivering of the patient or moving of the patient. Very helpful. And this is, I think, we need more modern and new modalities to get a better assessment of what we want to treat.
Great, great. So we have several questions here. I'm gonna, again, Mike, we'll start with you this time. What are the best clinical practices to keep in mind when treating below the knee disease?
Don't miss any blockages. Don't miss really the length of the lesion. Assess the diameter of the vessel correctly. I think these are key components for our technical, procedure, and clinical success for our patients. In the past, we always undersized balloons, so we did not get any good lumen gain. We inflated with 10, 12, 14, 16 atmospheres to correct calcification. And with this barotrauma, we even more harm than benefit the outcome. So I think with these modern modalities, we can create more stable lumen and better clinical outcome for one patient. And there's one aspect I would like to mention we did not discuss so much. We had also the great success for OCT for instant stenosis treatment. And I see more and more patients who had previous interventions having a drug-eluting stent or even bare metal stents in their proximal tibial arteries, and these block from time to time. And here also I use the Avenger device, the OCT guided revascularization, because I can really debulk these instant restenosis even in proximal tibial arteries.
Yeah.
Philip, how about yourself?
Yeah, I think, as we alluded to earlier, identifying dissection in below knee tibial vessels is very important. The lumen is so small to begin with, and if you have compromised outflow, then the entire procedure may not be, have long-term patency or even short-term patency at that. So identifying those. I also tend to, not so much as, oversizing, but I think, more of a low and slow strategy in terms of low atmospheric pressures when you're ballooning, and also for a more prolonged time gives you better results in tibials versus, femoral popliteal. So I think that also, and then vessel prep. So we do the atherectomy and then follow that by a balloon angioplasty to get the results that we want to see, and hopefully for a longer term.
I agree. I think my best practice is to use imaging and not just archaic angiography. No offense to being an angiologist, but really we need to have, I think we need to utilize our alternative imaging, OCT, IVUS or whatever. And I think we need to use it more because we just gain so much more information about the vessels, as you guys have pointed out, size, what's in the vessel, the type of lesion it is. I think that's my best practice for BTK. Imaging those vessels. I think it's so important. So we have another question here, and I'm gonna add to it as well. Why did you choose to adopt OCT guided technologies into your treatment algorithm for below the knee treatment? And as a learning curve for this, how long did it take you to really feel comfortable using OCT for those new users out there?
So of course, there's a learning curve with OCT interpretation. I think that's clear. You need a couple of cases, but I can definitely tell you that we had great support when we started a couple of years ago to do these cases. We started with easy cases and then definitely get more sophisticated cases. So support is needed for the learning curve, but I think after 10, 15 cases, you're quite familiar with OCT image interpretation. So this is clear, and I can tell you that we are now using OCT technology also in very challenging cases. And one aspect I would like to highlight, we did not mention yet, is I know where I am. You have a long CTO, you get a wire through, but the hell, you're not knowing where are you with the wire. Are you subintimal or even deep in the media? OCT tells you where you are, where your guide wire is, and what could be the next step. Is it better now to use a debulking strategy or go with standard balloon angioplasty if you're very deep in the vessel wall? Another advantage, I think, with an optimized image using OCT technology.
Philip, how about you?
Yeah, I think, there's great support, and just being able to do it on real-time patients and seeing, where exactly is the media, where's the external elastic lamina, the adventitia. And after you do a couple, you kind of get a sense of what that is. And I still have, support, and I say, oh, is that plaque or is that this? And they reaffirm with me. So having, being able to discuss with someone else, and then as you continue to use it and get more comfortable, it's pretty, learning curve is not too bad at all.
Yeah, I think when I teach new users, my thing is there's two things you have to know: what media looks like and what adventitia looks like. Everything else is fair game. And then you can get into the nuances of all the other stuff that's in there. But those two things really makes it more simplified. And once you see those and know those, and they're pretty distinct, it makes it much easier. And I think that's why it doesn't take as many cases to learn this. So let's see, I have another interesting case, I think alluding to what you were talking to Mike there. Any concern with using atherectomy devices like Pantheris in the subintimal or medial space after crossing CTO and wire is found to traverse in and out on the intravascular image?
So the question is, what do we want to achieve with the debulking strategy in subintimal or even in medial revascularization? Is it really helpful to use it? So this is definitely cannot be answered by literature so far. What I can say, if I do is see a lot of media calcification with a subintimal approach, yeah, you can use it. Yeah. But of course, the question is, what do we get with that? So we need a little bit more data for this to really adequately answer this question.
Philip, how about yourself?
Yeah, I feel like you're kind of playing with fire a little bit. You're in the subintimal space and you're very close to the adventitia. You know, versus when you're in the lumen and you're going from the inside out, you can peel away the plaque, but you're going from the outside in. You may not be as effective in taking out that plaque, even though you can direct it towards the plaque rather than the adventitia. So, you know, if I'm in the subintimal space, I'd probably more likely stent than I would try to do atherectomy. And usually you don't get into a subintimal space in the tibial or below the knee. That's usually more applicable to the femoral popliteal area.
Yeah, I would agree. And I think the real key on that is it's more of an advanced imaging type of look to it. The key is really when if you're doing atherectomy in that space, to really, I think, identify when you're within the media, because the media is on both sides. And you could rotate that device in there and you have to recognize this is media and you're inside it. And then the next real trick is to decide which side is the lumen and which side is the adventitia. And I think those are kind of advanced learning things that there may be a good discussion later on in another webinar, so to speak. But I think those are the two challenges in those aspects. I think you can use it when you're in the media space, but that's I think the key to doing that. Is there any other questions here? You know, and the other thing I mentioned before, what's really surprising to me is all the angiograms that I see that look calcified, and by criteria of angiographic that would be severe calcium or at least moderate calcium below the knee. When I get in there with the OCT imaging catheter, all that is in the media. And it seems like more and more I see it's medial calcium, and the luminal is more fibrotic tissue. I don't know if that's what you guys tend to see is what I see. And I think a second part of that question is that do you think this device, directional atherectomy per se, removing that inside plaque, is then better than rotational devices that are going to not really fracture that calcium when it's in the media itself?
Yeah, I think you're raising a very important point. So what I definitely learned with the OCT images is that we are dealing with mixed morphology. Based on angio, we see severe calcification, but when we dive into it and analyze with OCT, we typically see, as you just said, fibrotic, we saw calcification, and we can still attack this material with OCT. As you mentioned, it's probably not the best for really severe calcification, but it's typically not always severe calcification. It's a mixed morphology. But the angio assessment guides us in a wrong direction. So adequate morphology analysis is the important aspect here. And with the OCT, we can much better identify the morphology and then can really opt for atherectomy using a 6 French Panteras approach. And this is the advantage clearly here.
Oh, Philip, how about you in the calcium aspects?
Yeah, I think again, the eccentric type of lesions are more difficult to target with just a rotational. There could be one side that's more elastic and can expand and you get the lumen, but then as soon as you're done with that, it recoils right back. So you're not really targeting the lesion, and there's avenues for it to kind of push out of the way and come back in is the way I kind of theorize it.
And again, another question that's come from the audience. What Mike, you alluded to a little bit. You're using these devices in much more challenging cases below the knee. So what type of BTK cases do you find the most challenging, and where do you find OCT guidance helping you in those to get better outcomes and avoid complications?
Yeah, especially in very long calcified morphologies with mixed morphology, when we are diving in, these are, I think, the most challenging, not in terms of technical procedure outcome, but to gain a stable lumen over time. Yeah, this is our job is not to get a wire in and create a lumen with ballooning. I think our job is to maintain the lumen. Yeah. And I think with an atherectomy approach using Panteris, for example, we can really adopt to this and create from the beginning on stable lumen in these typically single vessel run of patients with CLTI, where it is so important to keep an artery open for a couple of weeks, months. Yeah. Based on these data, on the recoil data, we ballooned it, we were heroes for 50 minutes, and then after 50 minutes, we got losers, yeah, because the lumen recoils and we are losing the case. And this is the important aspect, yeah. Not just thinking about creating a lumen, maintain a long-term patency is so important for CLTI patient. And I think with this modern technology, we now have the opportunity to do so.
So,
Yeah, I don't have much more to add on this topic. I think
okay.
Littenberg.
I think, the most challenging BTK cases for me, obviously the Rutherford 6, where I know that they're going to have an amputation. And I really have to get a durable result, as you were talking about, Mike. And as well as in those cases, I really would rather have more than one vessel open. And I'd like to get two vessels in that sense, if I can add a peritoneal to a tibial. So I think and those are challenging cases, and you have to use much more contrast, much more fluoroscopy. Your time in the lab is much longer. So therefore, I think that OCT guided atherectomy allows me to use less contrast, less fluoro, and less time. When I'll do my atherectomy run, I kind of know what the image looks like on the inside. I know it's open. And so if I'm going to adjunctive balloon, I'll just put an adjunctive balloon. I don't add extra contrast in there. I feel confident that vessel's open. And so my first shot is when I go to put the device in. My last shot is after I've completed it. So I think those are the cases that are challenging, and I think it makes it a lot simpler and less complex, less contrast, less time in the lab. And I think those two things lead to less complications for the patients. So that's where I find the most challenging, where I like this device in that sense. So I guess we have no open questions left open. So we're kind of done with the question and answer phase. Unless you guys have any questions for there are topics, things, one last thing that you'd like to add to the audience that you can instill in their memory banks about this device and BTK. Philip, we'll start with you.
Oh, me. Oh, sorry. I think it's all about imaging. It's all about seeing what you're doing. And as we have more technology and the ability to do that, we should embrace that technology and not kind of be scared of it. We should see how we can utilize different kinds of technology, whether it's IVUS, whether it's OCT, whether it's MRI or CT scans preoperatively. The more data you have, the better you can treat your patients. And I think that we need to adopt that more in our practice moving forward.
Mike?
Yeah, not so much to add, actually. Actually, we saw a great case by Philip and showing us the real advantages of an OCT-guided intervention. My final statement would be, keep it open is the most important thing. Make it open, we are all good in that. Make it open is something we learned from the beginning on, get a wire through balloon, everything. But I think we need to change a little bit our strategies, keep it open. This should be our main focus for the future.
My last thoughts for everybody is, with a little bit of levity, if you don't adopt alternate imaging, you're going to become a dinosaur in this field. And if you want to not become one of those dinosaurs, the old time guys, you have to really look forward and I think add imaging to your armatoire of treating disease. So, Well, listen, both you guys, I really appreciate you being on here. I've enjoyed talking to you guys and listening to your thoughtful answers and your talks. And I know the audience has learned quite a bit from the two of you in this sense. So again, thank you. And thank you to the audience out there. And hopefully this will be the first of many of these talks that we give out there on webinars. So thank you again.